and today we'll be talking about the case history and examination of the mouth and other relevant structures. Okay, so before starting, of course, you all know, you must be knowing by now that when the patient comes to you, what's our main goal? Our main goal is that we provide him the best treatment, right? So, how is that possible? That is possible only when we are taking a complete, comprehensive case history. Okay, because we want to reach to a proper diagnosis of his or her problem or disease, right? And when we have diagnosed it correctly, then only we can provide the best treatment, isn't it? So that is why we have to take a complete comprehensive case history, right? So coming to the dental records. Dental records or the patient's chart. What is it? It's a document that records all the diagnostic information, clinical notes, the treatment performed, and the patient related communication that occur in dental office between you and the patient, right? And also, it has a mention about the consent to treatment. Okay. So, a dental record means all the information which you're taking from the patient. Okay, you're making maintaining its record. That means you're making a note of it, right? You're asking about his chief complaint, about other problems, about other things such as the socioeconomic status and all other related things which is required, like the past medical history, dental, anything, any treatment he has performed earlier, and other things, and your treatment planning which you're going to do, right? And you're also taking the consent. That means what? That means before doing any procedure, we need to have consent. That means permission from the patient, right? But when we are talking about the pediatric patients, here the patient is young, isn't it? So he or she cannot give his or her consent, so we take the consent from the parents or the guardian who is accompanying the patient, isn't it? So the consent is actually, it should be informed consent. What do you mean by informed consent? Is that we give all the information regarding the problem, regarding the treatment to the parent or the guardian. Okay, we mention about the risk factors, the advantages, disadvantages of that treatment, or any alternative treatments that are available. Okay, so all this has to be explained to the parent when we are talking about the pediatric patients, right? So when we are telling them all this, we are giving them the right or the autonomy to select or to say yes or no to the treatment, or to select if there are alternative treatments, right? So that means informed consent. So this is also a part of dental record. Is my voice audible to you? Kindly respond in the chat box. Okay, thank you for responding. So, coming to the importance of records, okay? So, why do we need to take the records? Of course, the first point, which I told you already, is that we want to give the best treatment, right? To provide best treatment for, to the patient. So, how is that possible? When we are taking all the records, all the information, right? So, that is one. Another point is that, when, for example, you're a pediatric dentist, okay, in future, for example, okay, now the patient comes to you and you want the orthodontic consultation for the same patient. So you are referring this patient to an orthodontist, say, for example, okay. So what happens is that when you have maintained, all the record of the patient, that referring, dentist or the specialist, he doesn't need to, again, ask everything and all the complete case history and all those things. No, he or she may just go through this record, and then they can start their treatment, whatever, okay, from that point, isn't it? So that is where it is helpful. Plus, for example, you get this, you are working in any dental facility, okay, and for some reasons you have, left that place, or maybe you have got transferred to any other, area or anything. So what happens? This patient whom you were following, for example, who was coming to you for the treatment, right? What happens to him or her? He will continue the same dental facility, isn't it? But then he or she will be treated by another dentist, isn't it, or another specialist. So that specialist, he will just go through the case history. He will come to know what all has been treated already and what all is left, what were the problems earlier, any complications, everything which you have maintained already. So that is how it is again useful, right? So, also, it is useful like in maintaining the standards of care in the community. Means what? Means that, for example, in case of any, maybe, any negligence, that means any errors or any, anything if goes wrong in the treatment, say, for example, by a doctor. So what happens in that case? The authority, they will go through all the dental records. They can then verify whether the treatment that was given was proper, genuine, what all, when it was given, everything, right? So that is how it maintains the standard of care in the community, right? So likewise, it's helpful in cases of forensic odontology, say, for example, it it's for example, in cases such as mass disasters, such as the earthquakes, or when there is a plane crashes, isn't it, or floods, or any such calamities, right? So what happens in such cases is that all the other body structures, the identification features of a person is not identifiable, isn't it, because of mass disaster. So what happens is that teeth, being resistant to such disasters, they can then be matched with the records, and that will help in the identification of that person, whether he is alive, whether missing, whatever. Okay, so that means it plays a role in forensic odontology as well. So that is why maintaining dental records is quite important. Is it clear so far? The importance of these records? Okay. Thank you for responding. Is it only one girl, Hind, who is listening to me? Or all others are listening to me? Hmm? All others are reading this. Okay, all are listening. Okay. I thought you people may be reading for exam tomorrow, isn't it? So relax, just listen to this. It will take half an hour and then you can prepare for exam, okay? So, coming to this clinical examination form, as you have seen already, we did that case scenario in a lab, right? And I explained you there a few of the things, right? So it is the same thing, but here it's very important for you. Why? Because, in level 9, inshallah, you will be dealing with patients, right? So for each and every patient, you have to take a complete case history, right? So the format will be same as you have seen in the manual, right? So this case history form is there distributed on 3 pages, as you know, right? So you filled it already. So likewise, you'll be given in your level 9 manual also, there is a case history, and you have to take the complete case history, right? So starting with the file number of the patient, the date he has visited the dental facility, then his name or her name, it should be written in full. That means your first name, the middle name, and the last name, right? And then gender you have to mark, then the address, contact number, very important, of course, right? In case you have to contact the patient for anything in future, right? And also the age has a significance. You have to mention the age, isn't it? Then if the mother or the parent, the guardian remembers the date of birth, that is very good. Then you have to make a note of it. And of course, your own name, the name of examiner, right? So all this you will be, making the note or recording on your this form. Okay. Then the most important thing is the chief complaint, right? That means, the problem, okay, for which the patient, all right, or the parent, has got this child to your dental facility. Okay, so why he has visited the dentist or why he has visited this hospital today? So that is because, problems can be many, but there may be one problem that made him or her to visit on that day, right? So that is your chief complaint. But what is important about it is that it has to be in patient's own words. That means you cannot use any scientific language. Okay, it has to be in a layperson language. That means you cannot use scientific terminologies such as the maxillary and mandibular teeth, or you may write molars, premolars. No, this all is scientific terminology. You have to avoid that. So you can simply write, if it is, for example, the patient has come for a pain, so you can write patient complains, or patient, if it is young, so patient's parent complains, right? So complains of what? The pain in the upper. You cannot write maxillary, so it is upper, okay, back region of the jaw. Okay, since when? Since 2 days, since 1 day, since 1 month, whatever. Okay, so that makes your chief complaint. But the chief complaint cannot be only pain, it can be anything. For example, the patient has come for any tooth that is mobile, right? So you have to write a loose tooth. Patient complains of a loose tooth in such and such area, right? And or maybe for bleeding gums, maybe for trauma, right? Or maybe there is irregularity in the teeth. That means they are not aligned well, so irregular teeth, right? Or it may be simply a routine checkup, isn't it? So they are much aware and they are getting their children for routine checkup. Okay, so then patient has come for a routine checkup. That's also a chief complaint. Or the patient, yeah, maybe the patient has come as a follow up. That means already he has taken the treatment. Okay, maybe the same dental facility or maybe previously at other dental facility. But the thing is that it's a follow up then, isn't it? So all this can be your chief complaint. Now, what is the history of present complaint? That means the history of present complaint means that this complaint, whatever, for example, he has told you pain. So now you have to explain this pain. That means when it started, how much time it is there, it is lasting there. Okay, that means how much is the duration. So how it starts, that means whether it is spontaneous, whether it is provoked with some sweets, with some heat, with some cold or anything, right? So whether it is provoked, whether spontaneous, and what is the type of pain, whether it is throbbing, whether it is dull, right? And what is the duration? Okay, how much time it lasts, when did it start, or whether it was relieved when the stimulus was removed, or whether it was had some relieving or aggravating factors, right? Or any treatment or medication that has been already taken for it. So all this you will be writing in the history of present illness or his history of present complaint. Okay, so coming to the relevant medical and dental history, of course you will take a note of it, whether any medical conditions for any patient, right? Maybe they may be suffering from any bleeding disorders, anything, right? So you have to make a note of it, right? Or any allergies, any scissors, anything. So past dental history means your whether the patient has been already taken treatment for the dental problems, right? So this will help. Why? Because what happens is that in case of, especially in the pediatric patients, you see that if the patient is already aware about the dental treatment and all, then what can you expect? of course, you can expect that he or she may be cooperative enough, isn't it? But if no past dental history has been mentioned, that means it is his or her first visit. So what can you expect? Of course, your modification ways, behavior modification techniques will be then different. So all this is important and having a significance. Got it? So, coming to the social and family history, of course, we have to know the socioeconomic status of the family. Why? Why socioeconomic status is important? Because we want to know whether they can afford the dental treatment, whether they're how is their education level, whether they're aware or not. So all this will be interrelated, isn't it? Or any family history, any disease that is running in a family, say hypertension of the parents and all, right? Because they have the hereditary, sequence there, right? So all this you have to mention. Then coming to the level of cooperation. Okay, so when we talk about the level of cooperation in pediatric patients, especially, it is very important, isn't it? Because there the cooperation is a main thing which will be related to your success of your treatment which you are given, isn't it? So the Wright has classified, this is a scientist named Wright, Wright, okay? He has classified the level of cooperation into three. This is cooperative. He does not mention uncooperative, okay? He says it is categorized as cooperative, lacking cooperative ability, and potentially cooperative, okay? So, what is cooperative? Of course, when the patient, the child who is a patient, who is your patient now, he is enjoying the treatment. He is very, not anxious. He is, following your instructions well. You're saying open mouth. You're saying anything to him. He is obeying you, isn't it? So he's enjoying the session and he's not apprehensive at all, right? So that means he's cooperative, right? Then there is another thing that is potentially cooperative. What is potentially cooperative? That means the patient, okay, at the start may show some uncooperative behavior, or he may be little shy, maybe it is his first visit, so you cannot expect, so maybe but it's not that you cannot convert him to a cooperative. That means after certain using your communication skills, your behavior modifications, your interacting with him, you can convert him to a cooperative one. That means, yeah, that means potentially cooperative. Okay. Then we have the lacking cooperative ability. Okay. What do you mean by lacking cooperative ability? That means, hello, am I audible to you? Anything you want to ask me? Because I cannot. Okay, I cannot understand the Arabic language written. If you want to ask, you can write in English, please. Okay, so another third point is a third level of cooperation is which one? Lacking cooperative ability. That means what? Means, for example, the patient comes to you and he or she is below 3 years of age, 3 or below 3. What do you expect? Of course, they cannot be cooperative. That is natural, genuine, isn't it? So that means they are lacking cooperative ability. That means they cannot be cooperative. They are too young to be cooperative. They cannot even understand the language well. So the thing is that young patients are the example of that. That means they are lacking cooperative ability, right? Plus, the second example of this is, for example, you have patients who are maybe disabled, maybe mentally, physically. So you cannot expect them to be cooperative as normal, isn't it? So they are lacking cooperative ability. Right. So this is the three level of cooperation that Wright has given, and you have to categorize the patient as such. Then chief complaints, I told you it can be anything. It can be a dental routine checkup, the follow-up, or any pain, any trauma, any irregularity, any loose teeth, any, discoloration, halitosis, anything. Okay. So coming to examination. In examination, you will be First of all, there is general physical examination. Okay, then there is extraoral examination and intraoral examination. Now, general physical examination means that your patient, when the patient enters your dental clinic, say for example, so you should have a look at him or her, and you see how is he walking properly, is he walking by himself, or is he or she being held by anyone or taken in a lap or walking himself, is he hyperactive, or is he or she being carried on this thing, the wheelchair, or whatever. Okay, so you have to have that sharp view of the patient. Okay, that means you will see, or what is his gait, how is he walking, what is the body type. So all this you will see, whether he's ectomorphic, mesomorphic, endomorphic. Okay, so all this comes under general physical examination. You'll make a note of it. Then you have extraoral examination. That means, first of all, you will see the lateral profile of a patient. Okay, so in lateral profile, you will ask the patient to look at the front. Okay, he is looking at the front straight, and you will stand by his side, his or her side. Okay, and you are looking at his side profile. That means his lateral profile. Okay, now how you will categorize the patient? You will categorize the patient as having straight profile, convex profile, or concave profile. Now, how? That is possible. You are taking 3 points, three imaginary points, okay, looking at a patient, okay, from the side. Okay, so one is your nasion. The second is point A, and then the third is pogonia. Now, which is the point? Nasion. Okay, I would have been in front to show you. Nasion is the point, it is the point at the intersection between the frontonasal bones or sutures. That means where your two nasal bones is meeting the frontal bone. That means on your forehead, between the two eyebrows, there is a depression type, okay, at the root of nasal bridge. This is the nasion. So this you will take as 1 point. Okay, then which is the second point? Point A, which is that is the deepest point on the lateral convexity of maxilla. That means what? The point which is below the nose. Okay, that point which is below the nose, at the deepest point. Okay, so that will be your point A. Then you have the third point, that is the prominent most point, that is the midpoint on the chin area. Okay, so these 3 points, when you imagine, you don't have to draw with a scale or a pen. No, you just imagine and you make imaginary lines. Okay, line joining these 3 points. If your imaginary line is straight, that means the profile is straight. Okay, if the imaginary line you have made by joining these 3 points is convex, that means the patient is having convex profile. Okay, and if it is concave, that means patient is having concave profile. All right, is this lateral profile clear to you? All right. Uh, Thanks for responding. Okay. Thank you, Hind and Batul, and all those who are listening to me. All right. So, coming to lips. So, lips will be competent or incompetent, isn't it? So, you will be categorizing into these two only. Okay. So, when the oral perioral muscles, they are at relax, they are relaxed and at rest. So what happens is that in some patients you will see that lips, that means the upper and the lower lip, they are in contact with each other, or they may be up to 2 millimeter apart. Okay, up to 3 millimeter, maybe 1 or 2 millimeter apart. So such patients, you will categorize them as having competent lips. Okay, and if they cannot close, that means the upper and the lower lips are not in contact with each other while the perioral muscles are at rest. So that patient you will categorize as incompetent lips. Okay. Then you have swallowing. Swallowing, you have two types of swallowing. Very important in case of pediatric patients. When you come to clinics, you will say it. Okay. In swallowing, there is Two types, of course. That is the mature swallowing and the immature swallowing. The other name of immature swallowing is infantile swallowing. Okay. So what happens is that, when you swallow, all of you try to swallow your saliva. Okay. When you swallow, what is happening? The tongue, where it is touching the ryugi area of the palate, isn't it? You swallow, all of you, and see, when we are swallowing the saliva, what is happening? Our tongue is touching our yugi area of the palate, isn't it? Is it so? Are you swallowing? Yes, very good, Rima. So that is your mature swallow. That means we all have mature swallow. But what happens in case of infants is that they have infantile or immature swallow. Okay, in that case, the tongue does not, contact the Yuga area of the palate. No, it protrudes outwards towards the upper and the lower lip. Means between the upper and the lower lip, it protrudes out. Okay, so that means they have infantile swallow, and it is considered normal up to the age of 1.5 to 2 years of age. All right. So after 2 years, if you see the infantile swallow or observe that there is infantile swallow, then we can mention it as retained infantile swallow. All right. So that is regarding the swallowing. Then speech, of course, you have to see whether he is talking normally, whether any blurring of any words or any alphabets, right? So that you have to make a note of it. Then TMJ, you have to check the TMJ for any deviations, for any clicking sounds. When the mouth is opening and closing, you have to palpate the TMJ. You have to see whether there is any clicking sound, any pain on opening, closing, any deviations, right? So you have to check the lymph nodes, you have to check the submandibular, submental, all these lymph nodes, you have to palpate them. Okay, whether they are painful on palpation or what, right? So all this you have to examine. This is your extraoral examination of these structures. So when anything, for example, notes you're checking and you're examining, but you find no problem, so you will write it as normal or NAD. What is NAD? No abnormality detected. Okay. So after this, you will write as normal, as I told you, right? So then you have intraoral examination. Now, coming to intraoral examination, you have to check the lips. For example, is there any lesions such as herpes infections, herpes labialis, or there are cracks in the corners of the mouth? That means they may be malnourished, or any other things, right? Or you have to check the mucosa for any patches, as you must have read in oral pathology, like any red and white lesions or candiasis, right? You have to check the gingiva, the inflammation, palate, any patches, anything. So any abnormality or anything which is, varying from the normal, you will make a note of it, right? You will write it then. Then tongue, you will see whether there is, inflammation of the tongue, glossitis, or there is a tongue tie or anything. Palate, you can see, for young children, we see whether cleft palate. For lips, we can see cleft lips. So all these things. So if you are examining now, if you do not find anything, what will you write? You will write it as normal or no abnormality detected, right? Again, one point I want to tell you, if, for example, in case of things which you are asking to the patient, that means, for example, you have not examined, but you have asked, for example, about past dental history, medical history, and all those things. Okay, in that you will write it as, what will you write? If there is no past medical history or dental history, you will write it as no abnormality mentioned or no relevant history. That means NRH. Okay, yeah, very good. No relevant history, NRH, or no abnormality mentioned, because you're asking, right? Whatever you're examining, there you will write as no abnormality detected, because you are trying to detect. Okay. Now coming to the dental stage, that means your dentition. That means whether there is a gum pad stage. What is gum pad stage? That means no tooth has erupted. Then the patient may be below up to 6 months of age, right? Below 6 months of age. So that means no tooth is present, upper and lower gum pads. You can see that means the you will tick on gum pad stage, isn't it? Likewise, if there is a primary dentition, all the primary teeth are there, no permanent tooth. That means primary dentition. Likewise, you know it already, I think. So likewise, early mixed dentition, the mixed dentition, late mixed dentition. That means in mixed dentition, in your case history, we have kept it easier, for ease and saving time, only as mixed dentition. But here, you know it that early mixed dentition, that means there may be only one or two permanent teeth have erupted, right? So mixed dentition, more permanent teeth have erupted. Late mixed dentition, there will be less of this one or two primary teeth have left and all others are permanent, isn't it? So that means your early mixed and late mixed dentition. Then you have permanent dentition. Permanent means what? The All the teeth are permanent. Okay. In mixed dentition, remember that even if there is one or two primary or permanent, whatever tooth, means it's a mixed. Okay. Even if one. Okay, so you will categorize it as mixed dentition, right? So then you have to give the teeth numbering. That's important. Okay, that means when you ask the patient to open mouth, okay, you will see which all teeth are present there. So you will write it in this chart which is given. Remember, we have to use the system which is called FDI, system of truth numbering. Okay, what is FDI, system of truth numbering? You should know. FDI means Federation Dentaire International. It's a French terminology, so that is why this name, is given by FDI. So how it's done for the permanent? Of course, you must be knowing it already. But just to brush it up quickly, that for the permanent, the quadrants are numbered by 1, 2, 3, 4, isn't it? And then the tooth number is given, starting from the midline towards the distal, right? And then that is your permanent. But for the primary, how do we number the quadrants? Like 5, 6, 7, 8, isn't it? And then we give the tooth numbering, right? 5, 1, 5, 2, 5, 3, 5, 4, 5, 5, right? Okay, is it clear? What are the other two tooth numbering systems? You should be knowing. But here in level 9 also, you will be using only FDI system of tooth numbering. Remember, okay, don't mix up with two or three, one at one place. You must have written FDI. In the diagnosis, you will write it as Zsigmondy or Parma. No, you have to use only FDI, okay? Remember that. Then other two systems you should know, okay? That there are other two tooth numbering systems also, like the Palmer or the universal tooth numbering system. In the intraoral examination, you will write everything that is there. For example, if you see an avulsed tooth, if you see atrogen, if you see any composite restoration, temporary restoration, as you know it already, anything which is there, crossbite is there, any developmental defects are there, if you see microdontia, supernumerary teeth, anything, so you will make a note of it, okay? And if you see any defects such as amelogenesis imperfecta, dentigenesis imperfecta, hypoplasia, anything, you have to make a note of it. Okay, and then if you see mobile teeth, malocclusion, irregular teeth, crowding, anything, so you don't have to miss anything. That's important. Then coming to your diagnosis, okay. So for diagnosis, there's something called as provisional diagnosis. What is provisional diagnosis? Provisional diagnosis is that we have not prescribed any investigations till now to the patient. So we are giving something called as provisional diagnosis. That means what is your conclusion based on the chief complaint and the intraoral examination and whatever history you have taken. So you correlate all that and you come to a conclusion, okay, and that makes your provisional diagnosis, right? Then when you have any doubts or you want any confirmation regarding anything wherein you cannot, for example, sometimes you think whether this caries is deep or not, so let me go for let me prescribe the IOPA to a patient or OPG or whatever is required. So that then you prescribe you ask him for investigations such as IOPA. What is the full form of IOPA? It is intraoral periapical radiograph. Likewise, the OPG or CT scan or MRI or blood investigation in case of any systemic diseases. Right? We rarely give, but in case of special cases, we do tell them to go for investigations, blood investigations. I mean, right? Then we come to something called as definitive or final diagnosis. What is that? That is the after no before the definitive diagnosis, we have something called as this investigation results. That means you are writing, you have to note whatever you are seeing. For example, you have told the ask the patient to do this IOPA, right? So now he got the IOPA and you are observing the IOPA of that teeth, for example, as you have seen in the case scenario, right? So then you will write it down. For example, radiolucencies observed in which part of the teeth? The enamel, dentine, okay, with normal pulp, or radiolucency of such and such tooth. Tooth is very important. Numbering of the tooth. Which tooth here? For example, there are 4 teeth seen. You have to, mention about which tooth you are writing. So tooth number, because I have seen in the case scenario of students who have missed writing the tooth number. Then how can you give the diagnosis? Isn't it? Some students, they have missed writing the tooth number even in the diagnosis. So this is not appropriate. Appropriate is you will write the problem, for example, dental caries with this tooth, or a symptomatic reversible pulpitis with such and such tooth. Tooth number is important. Or when you are giving the investigations, write which tooth number you are talking about. Isn't it? So all this is very important. Is this much clear to you? Any doubts so far? I'm sorry, I'm trying to, make it very short, but it's a long, chapter. So still I'm going so quick. I'm sorry for that, but I know you must be tired, so am I. But what to do? Okay, so it will be finishing soon, just maybe 5 minutes, another 5 minutes. Okay, so this is okay. Thank you. Thanks for responding him. All right. So coming to there is something called as caries risk assessment, as you must be already knowing, as I think we have been talking about it since level 6, right? So AAPD, American Academy of Pediatric Dentistry, it gives something called as CAT. CAT is not that cat, right? Which cat it is? It is caries risk assessment tool. Right. So we use this tool to categorize the patient as, being low risk of having caries, moderate risk of having caries, or high risk of having caries. Okay. So it has categorized, as you already know, based on 3 things: the clinical conditions, that means you're examining the oral cavity and you're giving categorization, okay, or environmental conditions, that means how is the system fluoride, is he using optimal, suboptimal fluorides, or how is his sugar intake, is he using the sugared snacks and all at meals or in between meals, if in between meals, how many times, right? So all this you will use. Then the general condition, always remember that when you get a patient who is mentally, physically, or anything, means we say that he is having special healthcare needs, right? So categorize straight away that patient into what? Into high risk category. Okay. And any systemic disease, such as he is having this low salivary flow, xerostomia, what will happen? Low salivary flow means more chances of having a plaque accumulation, more chances of having caries, right? So categorize such patients as having high risk. So go through this table. Any doubts, you can ask me. Here, I will not read all of this to save your time. Okay. So caries risk assessment tool, you have to remember, is that we take it, or we assess it at that point of time. So that doesn't mean, say for example, you have categorized the patient today as having low risk. Okay, now that doesn't mean he or she will be at low risk for the whole of his life. No, So we will again reassess him or her after 6 months, say for example, and maybe his dietary, this diet has changed, or his oral hygiene practices have changed. Maybe the stress factors have changed. So what will happen? He may have converted into moderate or high risk. So that gives us at that point, and we have to reassess it. Okay. So this can be used even by a non-professional. Okay. And here they have to remember that if the patient, okay, is at low risk, we can reassess or we recall him after 6 months. But if the patient has moderate and high risk, we have to recall him after 2 to 3 months only. I mean 3 to 4 months only. Okay. So there is that is about your caries risk assessment. Okay. Now coming to the treatment planning. What do you mean by treatment planning? Treatment planning is not something that you have done. No. Treatment planning is what you are going to do in the patient, okay, for all the problems that you have observed and made a note of, and you have come to some conclusion and diagnosis. Now you plan a treatment. That means I will do this with this tooth, with that tooth. This tooth needs, there is a space, so it needs space maintainer. There is a caries, it needs restoration. There is a pulpal exposure, it needs endodontic treatment. So you plan a treatment, or the patient is at high risk, he or she needs diet counseling, oral hygiene counseling, fluoride application, all this. So that is why it has been, divided into certain sections, such as the emergency phase, systemic phase, preventive phase, preparatory phase, corrective phase, maintenance phase, as you saw in the last page of your case in a case sheet, right, which you did in the lab, isn't it? So emergency phase is what that means. Your patient is disturbed. That means he or she is not able to do his daily activities, his sleep, he cannot even sleep. He is having such a pain that it's disturbing his daily life activities. He cannot he cannot eat, he cannot sleep. That means he is an emergency. Or he is having fever, he is having or extraoral swelling. So all this will be emergency, isn't it? Also in pediatric patients, especially, sometimes the parent is anxious regarding that in a child, they have seen that the tooth is very mobile, so they are anxious that he or she may inhale or swallow that tooth. That is an emergency. That means you have to extract that tooth on the same day. Okay. So this is emergency phase. Now, systemic phases, of course, when the patient is, having any systemic diseases, then you cannot treat him, as such. Of course, you have to contact the physician he or she is undergoing the treatment with. Then you have to take the consent. You have to see what all precautions is needed. So that is your systemic phase. Preventive phase is what? The all the preventive procedures, such as fluoride therapy, such as Pitt and Fisher sealants. Remember, you have an exam tomorrow. Pitt and Fisher sealants, right? That is your preventive phase. Or you have found that they are having more of snacks and more of sugars and chocolates, and also what is needed? Diet counseling, isn't it? Likewise, you have found oral hygiene is not good. So what is needed? The oral hygiene instructions, right? So all this comes under preventive phases. Then you have preparatory phase. Preparatory is your actual procedures, such as you go for some endodontic treatments, or you go for ortho consultations, or you go for extractions. Okay. Then corrective phases, for example, there is any space is there. Okay, you want to put a space maintainer, or there is you want to go for permanent fillings, or the crowns, stainless steel crowns, or you want to go for orthodontic interventions, the treatment. So that all will come under corrective phase, right? Then you have maintenance phase. What is maintenance phase? Maintenance phase is the recall. You have put the patient on recall, on follow-up. Why? Because whatever you have given the treatment, you want to reassess now. Or maybe there is a need of recall. For example, you have done half of the treatment, half you will do on the next visit. Or not only that, for example, you have put a pit and fisher sealant or anything, you have to reassess it after, say, for example, 2 to 3 months to see whether it is intact, whether some of it is lost, anything. Okay, this is an example. Likewise, you have to recall, or you have given the diet and hygiene counseling. Say, for example, now you have given the oral hygiene counseling instruction. So, what will happen? You have to now observe or reassess the patient whether he or she is following your instructions or not. So, all this is done in maintenance phase. Okay. So then, of course, you do what? You write the recall date. That means you have put the patient on a recall. Say, for example, after 2 weeks, 1 week, or the date, if you know, you have to write that. Your signature is important, and your name, and then the supervising staff who is supervising you. The signature of that staff is also important. Okay, all this is important. And there is also one thing, one more thing here is the informed consent. You must have seen, right? So you have to see, tick on whether you have obtained it or not. So that is also important. That completes your case history. Is everything clear to you? Any doubts? Please write in the chat box. There wasn't a single boy, I think, in the session, right? I think there was not a single boy in the session. Okay. Thank you so much, and thanks for your patient hearing, and all the best for tomorrow. See you all.